Hi and welcome back. This is week 6 of the Epidemics MOOC. This week we've been talking about various different measures, various different types of control for epidemics. Last week we talked about vaccination, and now we've talked about a variety of different other both social and behavioral controls, as well as other types of pharmaceutical controls. And we're going to address a number of questions related to that this week. We also introduced a video this week from our guest Moriah Szpara, who is a faculty member here at Penn State and works on herpes viruses. And I'll let you introduce yourself quickly, and then we're going to deal with some questions from the audience about herpes viruses.
Excellent. Well, my name is Moriah Szpara, and I did my PhD at Berkeley and a postdoc at Princeton before starting my lab here just about a year and a half ago. And we're studying herpes simplex viruses at the molecular and genomic and cellular level.
All right, so herpes viruses are something that a lot of people have heard about, and one of the sort of fascinating things about these viruses is that you can get infected, you can have disease symptoms, it can go away, it can come back again, and I think that's one of the things that people ask a lot of questions about, both all the various herpes viruses, both the genital herpes, varicella. People ask a lot of questions about shingles. And so one of the questions that's come up is, how much do we know about both how and why these viruses go through these cycles of quiescence, where they seem like they're hiding from the body? Is that what they're really doing? Are they hiding from the body at those times?
I would say yes, they are. I mean, it's a very useful strategy. It's different from the strategies of a lot of other viruses and pathogens, but to have the ability to establish latency or a quiescent form of infection is a really good way to allow that host to operate at a normal level, move around, and potentially escape again. And I think one of the most exciting things that we've learned in the field of herpes virology in the last few years is that people shed herpes simplex virus without lesions. So there was one concept that we used to have maybe a decade or more ago, that people were initially infected, latency was established, and then when they had a visible lesion, they were shedding and were infectious. And now we realize that the virus actually has lower level reactivations that go mostly unknown. You don't feel them, you don't see them, and yet you're transmitting virus to your partners or to others. Now that is a really impressive strategy on the virus's part to move around and infect other members of the population.
So when it's not been done with lesions, how's the virus shedding in saliva or what?
Yeah, just from skin. So some of the best studies were done at the University of Washington and the Fred Hutchinson Cancer Research Institute, and they're just swabbing skin in the genital region. They were looking for HSV2 initially, and then later this was redone with HSV1, and that is present in saliva. But these initial studies were done with genital shedding, and it's very impressive. The levels can be reasonably high with no observed phenotype and no pain felt. So that makes transmission a very different risk than if you thought you were only infectious at the time you had lesions.
So where is the virus when it's being shed from the skin? Is it in nervous tissue, or where's it coming from?
That's a great question. I mean, the initial site of latency and the site, therefore, of the initial first reactivation is in neurons. But those nerve endings come very close to the skin surface. And so what we presume is happening is not that the virus can miraculously pass through the epithelial skin and get out, but that it must be infecting just a small number of epithelial cells, enough to replicate itself and shed particles on the order of thousands or tens of thousands, maybe even 100,000. But not at a level that the immune system comes in and detects that with its surveillance mechanisms to create the whole cycle of inflammation and painful responses.
So is it doing something active to hide or avoid detection by the immune system, or is it just staying at really low levels, sort of flying under the radar?
That I don't think we know the answer to yet. These new data about the fact that people shed asymptomatically have come out just in the last 5 to 10 years. So I think people are now asking, well, what's different? Why do we get a lesion this time and not that time? And that question is actively being answered with new data coming out at each conference, I would say every year, but there's no set answer. It may be about the quantity, it might be about coincident other infections or other stresses, but I don't think we have a solid single reason why.
So in a related question, do you think that the lesions are, just to speculate, are the ideal strategy for the virus, or perhaps the ideal strategy is to go under the radar and have that low level release? What do you think?
I would have to say I've been influenced by what Rachel has talked about with social stigma and people's behavioral responses, and I would guess that the virus can spread more effectively when it's flying under the radar with these asymptomatic infections.
You mean people are avoiding the lesions? People are avoiding individuals with lesions.
Right.
Yeah, I mean that's something that we've talked about in terms of what other species do, and it looks like humans in particular really attend to visual cues, and especially those that our species thinks of as disgusting, and the lesions do evoke disgust.
Yeah, right.
And so we attend to them quickly, we orient to them, we remember them for a long period of time. You always remind me that if we were just lobsters, then we would pay attention to smells or other cues that may actually be much more diagnostic. But yeah, for a species that orients to visual cues, wow, how smart on the virus's part to go under the radar.
And I think there's a sense of personal responsibility too when you have people in partnered relationships, that a person who is aware and senses that they have a lesion or feels an infection coming on might behave differently of their own choosing, in addition to how others respond to that.
And the public health campaigning has actually fed into that, where when you're supposed to take therapy, it's when you may or may not have symptom, that you're supposed to be changing your behavior when you have symptoms. So there's actually been messaging around this as well that, for better or for worse, we're going to have to undo, so that people realize that this is something that they won't just have a trigger and then change behavior. They'll have to change their behavior in a more systematic fashion.
Yeah.
And so has this understanding changed the direction of how therapeutics are being developed? So where therapeutics were very often in the past targeted towards people that were towards minimizing lesions, and oftentimes people were only using them when they had flare-ups. Are there new therapeutics that are being designed for long-term use or to affect this shedding in the asymptomatic phase?
Yes, and I think it changes how we have to think about them, right? So that there were already things in the pipeline that were designed to be what we call therapeutic vaccines, so ones that would just reduce a person's symptoms and make that person feel better, make that person not have lesions. And
so
those
just to clarify, what's a therapeutic vaccine as opposed to just a drug?
Okay, that's a great question. So a therapeutic, we distinguish vaccines in multiple categories, but at least a couple that are relevant here is a preventative vaccine versus a therapeutic vaccine, and then I'll answer the drug part. So a preventative vaccine would prevent you from getting the infection, and a therapeutic vaccine says you already have this infection, we're going to make your symptoms more tolerable, or aim to make them more tolerable. And then having a drug, again, you presume that you already have an infection and you're trying to treat it and mitigate the symptoms. A cure would be fine too, and some drugs can affect a cure, but you can also have ones that just reduce symptoms and let you live on with this.
So the shingles vaccine, that would be an example of a current therapeutic vaccine, is that right? Or?
The shingles one, yes, would be.
But not
ideal.
the chickenpox one.
It's a bit of that is a difficult one actually to categorize into the two. When it's used as a chickenpox vaccine, the idea is that children would not then get the normal infection. They have antibodies to prevent infection. But the shingles vaccine is often given in both cases. It's given to people who don't yet have it to hope that you'll prevent infection, but it might also be given to someone who had chickenpox as a youngster. Perhaps I'll take this shingles vaccine someday since I had chickenpox, in the hopes that I will be able to stop my own reactivation when I'm 60 or 70 years old. So it's used both ways. That's a tricky one.
Fantastic.